Hello, I'm Dr. Ailey Kalapila from Emory University. In this National HIV Curriculum Mini-lecture, I'm going to provide a brief review on the prevention or prophylaxis of Pneumocystis pneumonia in people living with HIV. So this is going to be the outline of my talk. I will start with a brief background and rationale, followed by current recommendations for pneumocystis prevention, including the criteria for starting and stopping prophylaxis. We'll then discuss medications used for pneumocystis prophylaxis, followed by side effects caused by some of these medications, and then finally a summary. Now diving right into background and rationale, pneumocystis pneumonia, which I will refer to as PCP, is a major cause of pneumonia in people with HIV whose CD4 count is less than 200. PCP is caused by Pneumocystis jirovecii, a ubiquitous organism that has been classified as a fungus. PCP spreads by the airborne route, with disease occurring either by new acquisition of infection or by reactivation of latent infection. The symptoms seen with PCP pneumonia include fevers, dry cough, dyspnea, and hypoxic respiratory failure. Now, let's get into some details on prevention of PCP. The Adult and Adolescent Opportunistic Infection or OI guidelines have listed the following criteria as indications for initiating PCP prophylaxis to prevent active infection. These include having a CD4 count between 100 and 200 cells with a detectable HIV viral load, or a CD4 count less than 100 regardless of the plasma HIV viral load. It is important to note here that if a patient is receiving treatment for toxoplasmosis infection with sulfur-containing drugs, then additional PCP prophylaxis is not necessary. These are your medication options for primary prophylaxis to prevent PCP pneumonia. The first-line regimen that should ideally be used is trimethoprim sulfamethoxazole or trim-sulfa, and the preferred dosing is to take 1 double-strength tablet daily. And this is the same dosing that we use for toxo prophylaxis when the CD4 count is less than 100. So this is quite convenient that trim-sulfa provides prophylaxis against both PCP and also to prevent toxo reactivation. Now, alternative dosing for trim-sulfa can include taking a single-strength tablet once a day or taking a double-strength tablet 3 times a week. There are other alternative regimens for individuals who are intolerant of trim-sulfa. But what is very important to remember here is that these alternative options are dependent on the patient's toxoplasma serology status. For individuals who are toxoplasma IgG negative, alternative regimens for PCP prophylaxis include dapsone, either administered by itself or in combination with pyrimethamine and leucovorin, or liquid atovaquone, or inhaled or intravenous pentamidine. You can review the exact dosages on the National HIV Curriculum Opportunistic Infection Prevention lesson or by referring directly to the OI guidelines. Remember that you must always check a G6PD level prior to giving someone dapsone, because if you give dapsone to someone with G6PD deficiency, you can cause a hemolytic anemia. Also, aerosolized inhaled pentamidine is an option for PCP prophylaxis. It is dosed once monthly, which is convenient, but it is contraindicated for use in people with underlying reactive airway disease or pulmonary disease. Now, for individuals who are toxo IgG positive, alternative regimens are atovaquone or dapsone combined with pyrimethamine and leucovorin. And again, here too, you can review the exact dosages on the NHC OI prevention lesson or by referring directly to the OI guidelines. In general, any regimen that contains pyrimethamine can be extremely expensive, and this is mostly driven by the high cost of pyrimethamine in the United States. Now, these prophylactic medications can be discontinued if the patient is on combination antiretroviral therapy and has sustained a rise in their CD4 count to greater than or equal to 200 for at least 3 months. You can consider discontinuing prophylaxis for individuals with a CD4 count between 100 and 200, provided the patient is on combination antiretroviral therapy and has achieved viral suppression for at least 3 to 6 months. So there may be situations where you discontinued the PCP prophylaxis, but then it needs to be restarted. So the indications to resume prophylaxis are when the CD4 drops to less than 100, regardless of viral load. And prophylaxis also needs to be restarted for individuals with a CD4 count between 100 and 200 if they have a detectable HIV viral load. Now let's go over some of the common side effects associated with the medications used for PCP prophylaxis. With trimsulfa, you can see a rash, renal dysfunction, hepatitis or transaminitis, hyperkalemia, leukopenias, particularly neutropenia. With dapsone, it does contain a sulfa moiety, so if an individual has a severe reaction to trimsulfa, like Stevens-Johnson syndrome, for example, you should not use dapsone. If the reaction to trimsulfa is mild, like a transaminitis or a leukopenia, for example, then you can certainly try using dapsone. And then finally, I had mentioned earlier, which is that individuals with a G6PD deficiency should not be taking dapsone because they can develop a hemolytic anemia. Aerosolized pentamidine can cause a cough or a bronchospasm. Atovaquone does not have too many major side effects except that it tastes bad. Pyrimethamine is very expensive and it can cause nausea and vomiting and can also cause bone marrow suppression if it's not co-administered with leucovorin. And finally, intravenous pentamidine can cause hypotension, hypoglycemia, cardiac arrhythmias, and nephrotoxicity. So in summary, in people with HIV, pneumocystis prophylaxis is indicated when the patient is viremic with a CD4 of less than 200. PCP prophylaxis is indicated regardless of viremia if the CD4 count is less than 100. The preferred drug to be used for PCP prophylaxis is trimsulfa. Alternative regimens include dapsone with or without pyrimethamine and leucovorin, or atovaquone, or aerosolized or intravenous pentamidine. If trimsulfa is not used for prophylaxis, the selection of the alternative regimen for PCP prophylaxis will depend on the patient's toxoplasma IgG status. Remember to always check a G6PD level prior to using dapsone to avoid the risk of hemolytic anemia. Dapsone has a sulfa moiety, so if a patient is intolerant of trimsulfa, your ability to use dapsone depends on the severity of their reaction to trimsulfa. And if it's a severe reaction, it is best to avoid dapsone. But if the reaction is mild, then you can use dapsone. Pyrimethamine-containing regimens may not be as accessible due to cost reasons. And finally, you should continue prophylaxis until the patient has achieved immune reconstitution on antiretrovirals.